be interactive page.
Yeah.
So I would like to pick one or two students who are quite studious and sitting for long hours.
Yes.
I remember my old days where I used to be a backbencher in my MBBS days. After that, I've been forced to sit in the front rows. So that was the situation. So I got our own hospital, general hospital. It's a multi-specialty at IAPTCB, where we admit patients, especially related to endocrinology, like the DKAs or evaluation of precocious puberty that we have been discussing here. Just to, with permission of Dr. Sri Devi, I would like to tell, in few settings we use aromatase inhibitors.
Yes.
Like those who are already with growth hormone therapy and still they are short stature and there is delayed puberty, we use aromatase inhibitors, especially anastrozole with the 1 mg combination. But as you asked, what is the final output with the aromatase inhibitors? Hardly 1 or 2 inches, not much thereafter, because already they have been on growth hormone therapy. Now with the advent of once weekly growth hormone therapy, there is much improvement, because compliance has improved. Previously we used to use growth hormone daily. For past 4 years we are giving once weekly. So additional benefit of extra 1 or 2 inches we can produce maximum with anastrozole. Much more.
That is about growth hormone deficit, but people who come with anxiety that their child is short, they want postponement of
Exactly. Because these are most of the times these aromatase inhibitors we use it for peripheral causes, isn't it? So in that thing we don't expect as much as improvement with these things. So in such settings, aromatase inhibitors are recommended as per the bonus recommendations. Usually we call advanced bonus when chronological age and it differs by at least 1 year. So that is thing. So today I will try to limit my topic to few things. Rickets, you know better than me, being pediatricians, it is a disease of growing cortex, that's it. There is epiphysis, there is metaphysis, in between there is epiphyseal cortex which grows towards metaphysis. Because there is a zone of proliferation, then zone of hypertrophy and ossification towards metaphysis after some time, say as many people have told. Dr. Madhavi and Dr. Sri Krishnarji has told repeatedly about those Mekun Albright, all these syndromes where we have got polyestatic preparation inspection, which are relevant as far as osteomalacia rickets are concerned. And as Dr. Madhavi has told, there are rapid growth, around 30% by fetal life and 15% accounted by neonatal life and also at the time of puberty. So these are the two things. One is at infancy, second one is at puberty. At stages we see these two things, rickets and osteomalacia. Osteomalacia is a defective memorization of already formed osteoid, isn't it? So it affects both children and adults, whereas rickets is specifically towards growing cortex. So almost they are equal as far as pathophysiology are concerned. And I don't want to be didactic at this time. Only thing I would like to highlight in this figure is the first step, which is drug treatment. This is important. If you can tell in exams, you may get gold medal, which I have been missing for many days because there are 2 or 3 gold medalists in endocrinologist. Because I was always little bit rebellious, my HOD used to like me, but those who come from outside, they used to think that this candidate is rebellious, we should relegate him to second place. That happened my MD days also. That's for example. The first step, that is 7-dehydrocholesterol to 3-vitamin D is by UVB. Yeah. So UVB, and second conversion, this is by heat. 3-vitamin D to D3 is by heat. So if you can elucidate and tell your examiner, who will be bored with our answers, isn't it? Most of the times we tell many wrong answers. The first step is by UVB, second one is by heat conversion. So this is isomerization. So final conversion by both UVB and heat. So these things you know, sir. Vitamin D then converted to 25-hydroxylase and by 1,2-hydroxylase at the kidney. So finally it may get the catabolism or it may be interacting with other minerals and PTH. So this box one I would like to add. That's it. Usually you know better than me, sir, and students also. Breast milk contains very minimal amount of vitamin.
Sir, recommend vitamin D.
Vitamin D from the outside. And daily calcium accretion is around 3 millimoles per kg. Phosphorus accretion is 3 millimoles per kg. That means a baby requires at least 400 ml per kg. But how many babies are getting? So this is always hereditary. That means almost twice the requirement of a premature infant. Especially in those individuals who are weighing less than 1.25 grams or less than 28 weeks gestation, most of them, around 30%, are already vitamin D deficient and predisposed for rickets. And as you have been discussing, vegan diets without meat, and fear of plasticizers, all these things which we will not measure. Especially down in our Kokatpalli area, we are seeing lot of these premature puberty cases, because it is surrounded by these pharmaceutical companies. And you know, in India, the equality. So they will be discharging the effluents into the water, and they might be bringing. Yesterday also I have seen one male who is coming with gynecomastia and not being breast. When we done Ishtar hours, it was grossly elevated. Now we are approaching either with testicular ultrasound, that is the standard thing. Or if it is normal, then we are testing it is because of environmental factors. So right from Patancheru, that shock or all these things, unfortunately we are witnessing such endocrine disruptors, which you have been telling. Might be in air or water or through our food, whatever it is. So other causes of vitamin D are that, you know, some religious customs, and because both parents are working, putting their children in daycare centers, not exposed to sunlight, associated obesity, because it is estimated unfortunately 20% of Indian children are now becoming overweight, and pollution also decreasing new years. So there is no time for play except to play with mobiles. Nowadays they are bringing, parents are bringing their children and they are playing with mobiles. In my OPD, I had to tell the parents that please stop your children from playing with mobile games, because that has become custom nowadays rather than exception. And these are the points which I have been trying to learn in my MBBS days. Racket, rosary, hands and group, which I recently finding in my final exam of DM. Then because the textual is from same our PJ, we told that without knowing Harris and Sulcus, how can you pass? Because for 2 days continuous exam will be there, sir. I will be tired by at the end of the day. I missed this one, Harris and Sulcus. Then said, I will fail you. He is from Kashmir. Then I told, no, this boy is very hard working, because I used to pretend like that. So Harris and group usually we see, because I want to tell that point, because I missed that thing in my final exam. The diaphragm attachments are towards our ribs from last 6 ribs, sound to 12 ribs. So if you really want to see Harris and group, look at the lower part of our rib cage, especially on the right side. And patient is breathing, has to take deep breaths. And racket, rosary, you know, these are because of expansion of unmineralized ostia. That is casting physics of rickets. And caput quadratum, that is because of our bones are of 2 types. One is endochondral ossification, second one is membranous ossification. So most of the times what will happen is that as the brain gets enlarged, still there is another portion of our skull. So sutures will continue to expand. So that can lead to caput quadratum. And sometimes we can see that is also known as capocephalus, elongated anteroposterior diameter, and craniotabes. That means rickets is not exclusively limited to only endochondral bones. It also can affect the membranous bones, especially related to both face and even our skull also. And you know about these things, delayed teeth eruption, bleeding pelvic caries because of defect anomaly formation, because of weight bearing. Once they start to gain weight, various kinds of things, varum, valgum, resept. Resept means very simple. One side varum, other side valgum. So that is known as resept deformity. And swollen wrists. Swollen wrist is because of unmineralized proliferating ostia. And these are the unusual presentations, especially in IV settings you may see. They were present with hypotonia, and because of poor respiratory efforts, they may prone for recurrent respiratory tract infections, especially influenza pneumonia. Nowadays we are seeing a lot of influenza setting, athletic episodes, and because of low vitamin D, because it is immunomodulator, increased prevalence of tuberculosis, weight loss, non-specific bone pains and weakness, which may relegate to just it is a functional. All this may be because of vitamin D deficiency. And frankly, full-blown hypocalcium seizures, now and then we are with this. Recently we have seen one case with calcium of 6 and with a progesterone positive and prostaglandin positive, we had to give intravenous calcium. This ones are we have been discussed. According to theory, whenever vitamin D levels are less than 10, especially hovering around 5 or so, we can see rachitic changes. There is a lot of controversy going on. What are the normal ranges? Some say 20, some say 30. I am not going to delve into 30 because we can discuss for the days together, which is 20 because Institute of Medicine recommends 20, some other society comes recommends 30, and that other than the Harrison, he always tells about the 40, 50 also. Nowadays he is live or dead, I don't know. He watches for 40. minimum. Same as faculty. And the toxicity we expect if it is more than 100. That's why I will be repeatedly stressing vitamin D stores in unit never goes up further. If you are not giving any supplements by second month of life, definitely they are going to land in decades. The unfortunate thing is that many times our laboratories do all kinds of panels including calcium, and if you see calcium they just dismiss it as normal. They don't look at alkaline phosphatase, all those things. And main problem with alkaline phosphatase in parent range, you know better than me, is that up to 2 years of age they can be more than 3 times of alkaline further. By 2 years they will be 2 times, and again they will increase during our tubercle growth spurts. Only after 20 years of age, then they will become into, they will normalize into adult ranges. That's it. So we have to be careful about evaluating predatory alkaline phosphatase levels. This diagram I have carried just to show how bone formation and bone resorption occurs. Only thing I would like to tell about this thing is there is interaction between osteoblast and osteoclast through rank ligand and rank. Rank ligand is by osteoblast. This is one of the most sought after MCQs, isn't it? And rank ligand and the rank receptor is on the osteocyte and osteoblast. So there is a decoy receptor that is known as osteoprotozoa. These three things I would like to highlight. Osteoblast, rank ligand is stimulator, OPC stimulating is positive. So this is known as bone remodeling unit, which approximately takes 3 months in adults. So coming to management of these things, we either look for ionizable calcium, which is notoriously difficult in our Indian settings. So we most of the times we look for albumin adjusted calcium. That parameter universal. Albumin is we take test for 4.5, 0.8 for every 1 gram increment or decrement in the albumin ranges. And phosphorus would be normal. Calcium can be normal initial stages also. And some labs unnecessarily do these things. Active vitamin is not required. Only adds to cost of vitamin. Main thing is that no vitamin D. And initial phases, because alkaline phosphatase is secreted by osteoblasts, initial phases it can be normal. So treatment from your Nelson you can read all these things because at this time I would not like to go to that. But if you see these things, requirement gradually increases as the age advances. And in those patients who are difficult to follow, there was supraphysiological doses like arachidol injection was there in those days from 1 lakh to 6 lakhs units. After that to 50,000 IU every 1 to 3 months. And they coined a term known as Stoss therapy. This Stoss is a German word. German word means just a dump therapy. Stoss means throw. So that if some examiner asks you, you can tell Stoss therapy so that they will be impressed with you and giving full marks, isn't it? Stoss therapy is a German word. Stoss means a dump. You are dumping in 6 lakhs units here. So that is the thing. And follow up is, please remember, no need to take X-rays or this for changes for at least 3 to 6 months. So for 6 months, there will be gradual changes happening over and over. But within 1 week, you can see normalization of calcium and phosphorus adequately. And main caution is that once we are memorizing this already decalcified bone, there is risk of hungry bone. As endocrinologist, we see this hungry bone syndrome post-parental because one has been decalcified with high levels of leakage. Here also there is this. So initially we had to give calcium. Divide doses it is recommended because if you give calcium in single dose, it cannot be absorbed properly because there is constant fraction of calcium being absorbed. And we also sometimes we also have to add calcitriol, just like the post-parental hungry bone syndrome. So all these things can be stopped once serum calcium levels normalize. Again, I am stressing, no need for radiology to look after reappearance of calcification because it will take at least 6 months for radiology to get normalized and often phosphatase back to its base-specific range. So these are the prevention and tables are in our textbooks. Less than 1 year, 400. Some people even recommended up to 600 also. If you see this breastfed vitamin D deficiency dot scale, even up to 800 to 1500 units, up to 3 stop is also recommended. So this is not a fixed one. 400 is the standard one, but in such settings where they are exclusively breastfed for 2 years or so, so up to 1500 we can go. And in winter months, especially down north, because it will be winter, especially from Delhi onwards for 2 to 3 months. up to 5 surface, we can give this doses. And if the child is obese or on any treatment with these agents like enzyme inhibitors of antibiotics group, on HIV treatment, especially the protease inhibitors, 2 to 3 times of that the standard equal dose can be given in such settings. Obesity not exposed to sun. So these are not constant ones, it is not uniform but to each and every. So this one we are taking care nowadays because now we are into geriatric care more than 7 years, requirement will become higher and higher because it will be deficient absorption, 800, almost double that of our pediatric tests. Nutritional calcium deficiency is very rare. It is known as calcium crickets. In especially high fluoride areas like Nalgonda, Prakasam district, and excessive tea drinking, in our PG days, we used to drink at least tea once an hour, escape from the rounds, and whatever HOD tells us to once and just gone outside like that. And cereal based diet, premature infants, and vegans, because this avoiding milk we have been discussing earlier. So, frankly, it can lead to full blown calcium deficiency. So, there can be normal levels of vitamin D, but there will be low levels of calcium which can predispose to rickets. So far we have discussed nutritional. Next comes to one of the intermediate things, tumor-induced osteomalacia. I don't know how common it is in pediatric case, but we often keep seeing nowadays. It is benign tumor actually, sir. Very elusive tumor, difficult to detect. But it causes lot of problems, multiple fractures, osteomalacia, all these things by secretion of this hormone FGF23. So this FGF23 causes phosphaturia. So patient will have hypophosphatemia. Because hypophosphatemia is there, it will lead to elevation of PTH and then it leads to hypercalcemia, hypercalcemia. And first line of treatment is surgery, if at all we find the tumor. And the imaging of choice is gallium-68 to dotatate. This gallium-68 is specific for somatostatin receptor type 2. And you can impress your examiner by telling this thing. Dopamine is a linker. How this name is spelled? Tate is octreotide, because these are all somatostatin hormones. So Tate is octreotide, dopamine is a linker between gallium and octreotide. So in 90% of settings, this imaging can take these tumors. In those settings where tumor is still elusive, this is not available. This price is quite high. I think 5 lakhs injection fees costing for 1 month. It is a tumor monoclonal antibody and it is scheduled till we find out the tumor. It is also used for X-linked hypophosphatemias. So coming to hereditary is deliberately I put rare causes earlier. One is Fanconi syndrome. Fanconi syndrome is nothing but defect of proximal colored tubule deabsorption. It is generalized absorption, so it can lead to loss of bicarbonate, leading to metabolic acidosis, loss of phosphate leading to hypophosphatemia, and loss of glucose that can lead to glycosuria, all these things. Here, all these parameters will be normal, calcium, PTH, vitamin D, all these things. Here, we have to look for, somebody has told VDC, so we have to do VDC, and we have to see tubular maximum deabsorption of phosphate, that's why TMDGF for all these things. And there are few secondary causes of Fanconi syndrome in pediatric too, like our metabolic disorders. I have bought a book of pediatric endocrinology and metabolism 6 years back, sir. I read half of that thing. After that, I got lectured. There are so many diseases. How to remember all these things, you can only enlighten me. Now and then, I would like to come here and learn from these things, these metabolic diseases, actually. How to suspect and how to avoid these things. Because sometimes in our disease practice, we tend to miss these things. Like hereditary factor intolerance, mitochondrial diseases, glycostoria disorders, all these things. Because they can lead to secondary Fanconi syndromes. Fibrous dysplasia, I think I did not elaborate because this is because of activating mutation of our J-solve. Here again, FGF23 is produced by our osteocytes, means their metacells and osteoblasts. And this cave of our molecules, madam has already told, most of the times we are on the back. So we have to undress the child there, or upper back, buttocks, all these areas we have to see. And test tube prescription, they are given as irregular margins. Means cave of minus something like that. Cave of California, or coast of California, coast of minus something like that. Because there are beaches in US, I didn't find this, I don't know. But if somebody else for fancy things like a cost of California, cost of mining. This is cost of mining. Actually, this is mining. And endocrine hyperactivity, like madam has told about precocious puberty, growth hormone excess, Cushing's disease already. I don't want to go into those details. This one, sir, this enigmatic disorder has been there for almost a century. In 1923, Robinson first saw this, but only after 25 years, this disease entity was first described. Most of the times, we do alkaline phosphatase, we don't give much importance. Alkaline phosphatase has got low limit of normal also. So, by reading those values, especially in children, we have to be careful in setting of records whether this alkaline phosphatase is normal or high or low. So here defect is in alkaline phosphatase. Because alkaline phosphatase is non-tissue specific. It can come from osteoblasts or from any other sites. Here the problem is most of the calcium, vitamin D levels will be normal. But how to suspect? By doing this pyridoxal phosphate. Because this is one of the substrate for alkaline phosphatase. This is elevated. Though they have mentioned from the textbook inorganic pyrophosphate, it is commercially not available. Only pyridoxal phosphate is available from the what is that laboratory? Lab labs. Other testing is nowadays because of availability of WES, whole exome sequencing, we can do genetic testing. There is one enzyme available, sir. DNA supplement means tissue non-specific alkaline phosphatase. So it is named as aspartase alpha. It is given subcutaneously daily because half-life is 5 days, sir. So it is given 6 days in a week with 1 day drug holiday. Daily it is given subcutaneous injection. Previously, one of the modalities advocated was bone marrow transplantation, but with availability of this recombinant enzyme, EMT has gone into second phase. Exact opposite one is because of hyperphosphatasia, but here defect is different. OPG deficiency, osteoprotogery. She is clicking photos, madam. What is osteoprotogery? Because we have clicked that photo also initially. Where is that osteoprotogery? Just it is not an example. Just like this one. That's what you would like to have. Osteoblast, simple, easy. This is stimulation pathway, this is inhibitory, OPC. Now because this OPC is offset, what will happen? Constant stimulation of osteoblasts do happen. That's what here. Very simple. If you remember basics, it is more than enough to be a good practitioner. So constant osteoinjection due to excessive release of phosphate. And this is the one, sir, you have been seeing much more than us. It is one of the most common causes of hereditary defects. Previously it was dubbed as vitamin D resistant defects. Though it has been described in 1958, after that there was lot of knowledge of this thing till 1990s. Then they found out in 1995, first this loss of FXG mutation, it is endopeptidase. Actually, what will happen? This endopeptidase degrades this FGF23. In the absence of this thing, FGF23 will increase. FGF23 comes from the osteoblasts and osteocytes also. So FGF23 directly suppresses our active form of vitamin D. It is very easy to understand. And as we have discussed previously, so there is a treatment for this excessive FGF23, that monoclonal antibody, which we use it for hereditary osteomalacia, that is Burosumab. And these things, kg body weight, you can read from the textbooks. Very important thing, practical implication is that if the patient is soaring, means patient parents are soaring, they bring this injection from UK or US, immediately stop calcium and vitamin D or whatever it is there, because they should be given to them. Because it is immediately going to be active. So unnecessarily we are using the opposite changes. Till that is available in India, this is a treatment we have been giving, still we are giving in few patients. That is active form of vitamin D, cancer trial, along with the phosphate. With availability of AdFast in granules, previously we used to prepare all the solutions giving from Subhash Road, phosphate, and Dr. Sinagesh was very well versed with these things. I don't know about that shop. Sinagesh and we are very close friends. We have been colleagues in care hospital. So how to mix that phosphate solution? There were two compounds, dibasic phosphate. I always get confused with those things. But with the availability of AdFast granules, now treatment has become simplified. Starting dose is 40 milligrams per kg body weight. Titration is achieve the lower limit of normal of phosphate. 2.5 to 4.5 you say. Up to 3 you can try target. In this thing, you can use citric acid. Because once you are giving phosphate, what will happen? It will stimulate the pH. It can lead to unnecessary second hyperparathyroidism. So now there are schools of theory that you can add citric acid. Citric acid is nothing but the calcium sensing receptor blocker situated on the parathyroids and renal tubules. So it allows the usage of lower dose of phosphate and calcitriol and reduce the risk of calcinosis. So monitoring as usual with, like other tests. Every 3 months height monitor, kidney ultrasonography to detect the, because we are dealing all these phosphate, all these things, deposition of calcium, and to look for any improvement in rachitic changes and bone changes. But it is one of the difficult diseases to follow as far as insulin and phospholipids. But the fortunate thing is sometimes the disease may improve as the age advances. But sometimes disease may enter into the compound phase where they may not require phosphate supplements. Instead, they may require growth hormone therapy because they are growing short. So growth hormone therapy in some cases we are looking at. But still they have got multiple fractures or diseases. Now these are very, very rare diseases. HHRH, hereditary hypophosphatemia rickets with the hypercalciuria. The popular name for this one is sodium phosphate transporter 10 disease. So hypercalcemia, hypercalciuria, where we shouldn't give calcium in these settings, unlike other rickets. So sometimes when we suspect that in the prenatal phase group, we have to monitor for urine calcium levels also. Already there is hypercalciuria, one should supplement with calcium. The defect is here in phosphate. Similar things. There is another product channel which is in the our kidney is having so many transporters. It has overwhelmed our knowledge. Daily we come across one new thing as far as renal system is concerned. This product channel, how it interacts with the previous one. Sodium phosphate transporters, these are all hypotheses. But simultaneously, it can also lead to aminoaciduria, glycosuria, hypercalciuria, phosphaturia. That means hypophosphatemic regrets with hypercalciuria, which is popularly known as gland disease because it belongs to chloride channel. And here if we measure protein, usual albumin stick will be normal, albumin will be normal because albumin is high molecular weight. Here we have to measure beta 2 microglobulin or retinol binding protein which are available in. But the problem with measurement of beta 2 microglobulin is that degrades in acidic urine. So normal urine pH is usually we take it as from 5 to 7.5 like that. Especially if pH is less than 4.5, then we should measure beta 2 microglobulin. Then we have to measure retinol binding protein. So these are all other things which you can learn in later phase of your life. There are other rare things like autosomal dominant hypophosphatates, autosomal with the expansion and explosion of our knowledge. There are so many mutations coming into this picture, and DMT1, DMT, these are so many enzymes related to our calcium and phosphate metabolism, secondary kinase, and these things I would like to highlight because these once we admit the patient, we can evaluate by measuring 24 hours urine, calcium, phosphate, all those things. But once a patient is receiving IV therapy, especially with new peri-oxymotos, there will be elevation of FGF protein, transient. So, yeah, for next 1 week, there is a risk of hypophosphatemia with IV therapy. So, sometimes patient comes here with extreme weakness, post-iron injection, you have to check the serum phosphate levels. Similar with aluminum. Nowadays, nephrologists are not using aluminum binders. Instead, they are using either calcium binders or sevelamer. And there is one very rare irritable liver syndrome which can cause phosphaturia and nitrogenate. This phosphate we are no longer using. This is a non-nitrogenous bisphosphate. Nowadays, what we are using nitrogenous bisphosphates like golden red kind of those things. And last slide is about vitamin D dependent rickets. Previously, they were known as vitamin D resistant rickets, type 1 and type 2, very simple. Again, we will go back to first slide that we finished on this. Here, if defect is there, it is type 1. If downstream defect is there, means on receptor is type 2. That's simple. Because vitamin D receptor is on multiple tissues, not only on bone, all these things. There is necessary for the growth of hair follicle, all these things. So vitamin D receptor defect is there. There will be alopecia. But the phenotype of alopecia varies. Some people may have total alopecia, some people may have sparse hair. As age advances, alopecia severity also may increase. So if you see alopecia, it's suggestive of type 2. Vitamin D deficient rickets. If it is not there, that doesn't mean that it is ruling out type 2. So this is the last line. So in vitamin D type 1, because one of hydroxide is deficient, we can replace with digital dose of our calcium triad. So that is very simple treatment. But in type 2 it is very hard to treat because vitamin D downstream is not acting. So next step what we have to do, we have to give extreme doses of calcium. Even up to 9 grams per meter square. Means in adults it may go up to 15 to 20 grams also. When we are giving such a calcium, we have to look for hypercalciuria because of risk of stones formation. So this is one of the things that we have to rectify. And this slide, I think I finished in time so that our lunch won't get delayed. Thank you very much.
Yeah. Apart from defect, of course, everybody knows and manages most of the nutrition defects and resistant variety usually sent to endocrinologists or nephrologists. But what we are seeing in the present generation of children, they complain of some pain in the legs.